So what do male salmon trout, the search for a cure for menopause symptoms, and like a hidden microbial battleground all have in common?
That is quite the list.
Right. Today, we're taking you on a deep dive into a wildly futuristic treatment. We're looking at what happens when pristine, cutting-edge regenerative medicine comes directly into contact with the bustling, chaotic, and just incredibly crowded ecosystem of the human body.
Yeah, because when you think about advanced aesthetic medicine, the image that usually comes to mind is, a perfectly sterile laboratory.
Glowing vials, precise measurements.
Exactly, biological perfection. But when you actually introduce those therapies into the mucosal surfaces of the human body, well, the results depend entirely on how well we understand that local, messy environment. It's this wildly dynamic, constantly shifting biological neighborhood.
Which really brings us to the core mission of our deep dive today. We are exploring a fascinating frontier in women's intimate health. So, clinicians are now injecting these highly purified DNA polymers specifically derived from the gonads of male salmon trout, of all things.
Which is just incredible.
It is. And they use it to restore vulvovaginal hydration, elasticity, and comfort.
I mean, it sounds a bit like science fiction, right?
Totally.
But before a clinician can actually harness the power of this fish-derived DNA, they have to ensure the local cellular neighborhood is completely safe, like ready to receive it.
Because if they don't, I imagine they risk throwing a highly advanced, very expensive treatment into a totally hostile environment.
Exactly. So today, we're going to explore the meticulous detective work clinicians perform to screen for active vulvovaginal infections, way before they ever pick up a needle.
And for this, we're pulling from a pretty massive stack of clinical guidelines, right? We've got protocols from the CDC, the American College of Obstetricians and Gynecologists, and the U.S. Preventive Services Task Force.
Yeah, alongside some really specific aesthetic clinic protocols and laboratory testing manuals,
Yeah.
we need to look at exactly how modern medicine balances, rigorous infection control with advanced tissue regeneration.
Right. But to understand why the screening is so crucial, we first have to understand the science of the treatment itself. We're talking about polynucleotides, highly purified technology, or PNHPT.
Yes.
So let's unpack what is actually in that syringe. When we hear fish DNA, we might imagine, I don't know, injecting active swimming cells.
Which would be terrifying.
Right. But this is fundamentally different. It's the raw, purified building blocks of cellular life.
Yeah, so after this really advanced purification and high-temperature sterilization of the salmon trout gonads, what remains is a highly concentrated medical-grade matrix. It's made of these long-chain nucleotides.
Which are basically the fundamental rungs on the ladder of DNA and RNA.
Exactly. And when a clinician injects these high molecular weight DNA chains into the deeper supply line layer of the mucosal skin, that's the lamina propria, they trigger two main mechanisms.
Okay, what's the first one?
So the first is physical hydration. These long chains have this three-dimensional gel structure that makes them incredibly hydrophilic.
So they love water.
They love it. They act like these biological sponges, just binding massive amounts of water immediately upon injection.
Wow. And the second mechanism?
The second is cellular signaling. So these polynucleotides physically bind to specific cell surface receptors on human fibroblasts.
And fibroblasts are like the construction workers of our skin and tissues, right?
Yeah, that's a great way to put it. They're the cells responsible for building the structural scaffolding. So the polynucleotides essentially signal these construction workers to multiply and start furiously producing new collagen.
And elastin and all those specialized proteins that lock in moisture.
Yes, it's giving the tissue the raw materials and the chemical signal to repair itself from the inside out, which is why it's a highly sought-after treatment for genitourinary syndrome of menopause, or GSM.
Right, which encompasses that chronic dryness, tissue thinning, and the severe discomfort that happens when estrogen levels drop, like during menopause or after certain breast cancer treatments.
Exactly. Women are really searching for non-hormonal ways to restore the actual structural integrity of that tissue.
And polynucleotides offer a biologically plausible way to rebuild that integrity. And this is but the clinic protocols are incredibly strict about contraindications.
Very strict. A clinician cannot proceed with this treatment if there is, say, active thrush, bacterial vaginosis, any active genital infection, or unexplained bleeding.
Okay, let's unpack this. I kind of look at this like gardening. You wouldn't apply incredibly expensive high-tech fertilizer to a garden that is actively being overrun by aggressive toxic weeds.
No, you definitely wouldn't.
Right. The fertilizer won't help the flowers. It might just get lost in the chaos, or, the weeds might hijack the nutrients and disrupt the entire root system.
If we extend that gardening analogy, the soil chemistry itself is completely wrong when an infection is present. The local immune system is basically in a state of dysregulation.
Because it's fighting off the weeds.
Exactly. It's actively pumping out inflammatory cytokines to fight a fungal or bacterial invader. And because the cellular environment is just engulfed in this inflammatory response, the very receptors the polynucleotides need to bind to on those fibroblasts, they might be compromised.
So the local enzyme environment is completely altered.
It is totally changed, yeah.
But here's the thing. A patient might just assume their itching, burning, or discomfort is just a normal part of aging or menopause.
Which happens all the time.
Right. They might walk in saying, I'm dry and irritated, give me the regenerative treatment, when they actually have a raging infection. If symptoms are that unreliable, how does a clinician know the invisible weeds are even there?
Well, the sources actually point out a staggering statistic on this. 50% of women with bacterial vaginosis, or BV, are entirely asymptomatic.
Wait, 50%?
Half. They have absolutely no idea they have it, because BV isn't always associated with typical soreness or irritation.
Wow.
So relying on someone to self-report an infection they don't even know they have, it's a recipe for clinical failure. This necessitates rigorous objective screening as a mandatory first step.
So if symptoms are essentially a coin toss, the clinician has to map the local ecosystem directly.
Exactly.
We have to move from the consultation chair to the clinic's microscope, because the traditional gold standard methods for diagnosing these infections right in the office, they rely on some very specific physical clues.
Yeah, we have to look at the physiological realities of the microbiome. Take BV, for example. BV is not an infection caused by a single invasive bug that you just catch.
Sure, it's more complicated than that.
It is. It's a profound disruption of the normal native ecosystem. A healthy vagina is dominated by lactobacillus bacteria, and these beneficial bacteria, they consume glycogen and produce lactic acid.
They essentially create a hostile acid bath, right?
Basically, yes. By keeping the pH between 3.8 and 4.5, they physically prevent other, more opportunistic bacteria from multiplying and taking over.
But when those lactobacilli are depleted maybe by hormonal changes or antibiotics or certain hygiene practices, the pH rises, it becomes more alkaline.
And that alkaline shift allows a mixed array of other bacteria, primarily Gardnerella vaginalis, to experience a massive population boom.
So the neighborhood basically gets taken over by a bad crowd.
Exactly. And to diagnose this shift in the clinic, doctors historically use something called the AMSIL criteria.
Okay, what's that?
It requires 3 out of 4 specific signs to confirm BV. So the first is a thin, white, or gray homogeneous discharge.
Okay, pretty straightforward.
The second requires the clinician to literally test the fluid with pH paper to confirm that alkaline shift we talked about, above 4.5.
Got it. What's the third?
The third criterion involves this fascinating bit of rapid chemistry. It's called the positive amine test, or a bit more informally, the whiff test.
The whiff test, seriously?
Seriously. The clinician takes a sample of the vaginal fluid and adds a drop of 10% potassium hydroxide, or KOH. When BV-associated bacteria multiply, they produce specific metabolic byproducts called amines. And when the highly alkaline KOH hits those amines, it instantly releases a volatile, distinctively fishy odor right there on the glass slide.
Oh, wow. So it's an immediate chemical reaction confirming the presence of those specific bacterial byproducts. They just literally smell it.
They literally smell it. And the fourth criterion of the AMSIL test requires the clinician to use a microscope to find what are called clue cells.
Clue cells?
Yeah. Under a saline wet mount, a normal vaginal epithelial cell looks like a clear, flat paving stone with really sharp, distinct edges.
Okay, I can picture that.
But in the altered ecosystem of BV, that cell becomes so heavily coated and crusted with those overgrowing Gardnerella bacteria that its borders become completely obscured and fuzzy.
Oh, interesting.
It looks like a glass window that's been heavily frosted with sand. Spotting those clue cells is a definitive hallmark of BV.
Now, the guidelines also highlight a massive red flag regarding how to test for this, right? The AAFP and the CDC guidelines state you should never use a standard bacterial culture in a petri dish to diagnose BV. Why is that?
Because Gardnerella is part of the normal flora in many perfectly healthy women. It's just a natural resident of the ecosystem.
So it's supposed to be there, just not in huge numbers.
Exactly. So if you culture the fluid in a petri dish, it will absolutely grow, giving you a false positive. Culturing for BV is essentially useless because BV is about the chaotic imbalance of the entire flora, not just the mere presence of a single bacterium.
Right. So BV is what happens when the bacterial balance tips. But bacteria aren't the only residents in this ecosystem. What happens when fungi try to stage a takeover? Like, we're talking about yeast infections, formerly known as vulvovaginal candidiasis.
Right, so for yeast, the clinician again relies on the microscope, but uses a different chemical trick. They take the swab sample and apply that same 10% KOH solution, but this time the goal is destruction. Yeah, the KOH completely dissolves the human cellular material. It literally melts away the vaginal cells, but it leaves the tough, chitin-based cell walls of the fungus intact.
Oh, that's clever. It clears the visual clutter so the clinician can hunt for the physical structures of the yeast, like specifically the spores and the long branching structures called pseudohyphae.
Exactly. And unlike in BV, a pure yeast infection usually doesn't alter the acidic pH of the environment.
Okay, I have to pause here because we are talking about taking swabs, dropping acid on them, smelling them for chemical reactions, and peering through a tabletop microscope looking for, like, fuzzy paving stone.
It is very hands-on, yes.
Right. But if a patient is paying top dollar for space-age, highly purified salmon DNA to regenerate their tissue at a cellular level, isn't there a more high-tech way to screen for these infections? Like, what if the clinic doesn't have a microscope handy, or the doctor simply misses a clue cell?
Well, you're not wrong, and the medical guidelines actually acknowledge this exact vulnerability.
Yeah.
I mean, while microscopy remains a cost-effective standard, it is highly subjective.
Right. It depends entirely on the skill and the eyesight of the person looking through the lens.
Exactly. The CDC notes that in modern settings, or when microscopy is inconclusive, clinicians absolutely shift to advanced molecular technology. We are currently living through this molecular revolution in diagnostics, moving from, subjective human observation to the objective precision of genetics.
Which brings us to nucleic acid amplification testing, or NATE. Instead of hoping to visually spot a bacteria or a fungal spore under a microscope, NATE hunts for their unique genetic code.
Yeah, NATE utilizes techniques like polymerase chain reaction, or PCR.
Which we've all heard a lot about lately.
Right. It extracts the DNA or RNA from the swab and uses thermal cycling, so rapidly heating and cooling the sample along with specific enzymes to copy or amplify target genetic sequences millions of times over.
So if you imagine looking for a microscopic needle in a haystack, NATE essentially takes that single needle and copies it until you have a haystack made entirely of needles.
That is the perfect way to visualize it. It makes the invisible undeniably visible.
And for sexually transmitted infections, NAT is the undisputed gold standard, right? The guidelines state you should only accept NAT for detecting chlamydia and gonorrhea, but the impact this technology has had on trichomoniasis is especially profound.
Oh, absolutely. So trichomoniasis is caused by a microscopic parasite. The historical method for finding it was watching it physically swim around on a wet mount under the microscope.
That sounds difficult.
It is. Because the problem is they die very quickly outside the human body and they just stop moving. Then they blend in with the surrounding cellular debris.
Of course.
But because NAT doesn't rely on movement, just the presence of genetic material, it detects 3 to 5 times more trichomonas infections than a traditional wet mount.
Wow, 3 to 5 times.
Yeah. It catches the hidden infections the human eye just misses entirely.
And clinicians are now using molecular tools for BV and yeast, too. The sources detail some specific tests, like the Affirm VP3, which is described as an oligonucleotide DNA hybridization probe.
That's a mouthful.
Right. Let's translate that into plain English.
So think of DNA like a zipper. An oligonucleotide probe is basically a synthetic customized half of zipper designed in a lab to perfectly match the genetic sequence of a specific pathogen, like Gardnerella.
Okay, so it's looking for its match.
Yes. And when the probe finds its exact match in the patient's sample, it zips together and sends off a fluorescent signal.
And the Affirm VP3 doesn't just ask if the bacteria is present, it actually measures the concentration. It looks for a threshold of, I think, greater than 500,000 colony-forming units per milliliter.
And that threshold is critical. Remember, a few Gardnerella bacteria are normal. Finding a few stray weeds doesn't mean the garden is ruined.
Right.
But hitting that 500,000 mark proves you aren't just looking at innocent colonization. You're looking at an active, overgrown bacterial army that is actively altering the ecosystem.
There's another molecular tool mentioned, the OSM BV Blue test. It takes a different route, looking for enzyme activity rather than DNA.
Yeah, it detects the presence of vaginal sialidase. That's an enzyme produced in massive quantities by BV-causing bacteria.
So if the enzyme is there, the test physically changes color.
Exactly. And for complicated recurrent yeast infections, the FDA has actually cleared PCR panels to map out the exact rare strain of yeast causing the issue.
What's fascinating here is the beautiful symmetry of this whole clinical process. Clinicians are utilizing highly advanced DNA amplification, genetic probes, and, synthetic zipper halves to map the exact molecular blueprint of an invading pathogen,
Yes.
just so they can guarantee the tissue bed is safe before they inject a different set of highly purified DNA blueprints, the polynucleotides, to heal the tissue.
They're essentially using DNA technology to secure the ground before DNA technology goes to work. It's brilliant.
It really is. Now, there's another detail about these molecular tests that fundamentally changes the patient experience. For a lot of these NAD panels, vaginal swabs can often be self-collected by the patient in complete privacy.
Which is huge.
Yeah. The data shows self-collection is exactly as accurate as a clinician-collected swab. It lowers the barrier to entry, it reduces discomfort, and it delivers the exact same molecular precision.
It is a massive win for patient autonomy, for sure. But, having access to this incredible arsenal of diagnostic tools, from simple pH strips all the way to multi-target PCR panels, it brings up a critical logistical question.
Okay.
With all this technology available, does a clinician run every single one of these molecular probes on every single patient who wants a polynucleotide injection?
Right. Does every patient get the full barrage of nets before the needle? Well, the clinical guidelines dictate a highly targeted, evidence-based approach rather than just a blanket testing strategy.
Because testing everyone for everything is wildly expensive, and it can actually lead to harmful overtreatment. The decision of who gets tested is totally driven by the patient's individual risk profile.
So let's look at asymptomatic patients. Say a woman comes in for polynucleotides to treat severe menopausal dryness. She has no unusual discharge, no odor, no itching. According to the CDC and the USPSTF, routine screening for BV in asymptomatic women is actually not recommended.
Right, because treating an asymptomatic shift in flora can cause massive collateral damage. I mean, pumping a patient full of antibiotics just to fix a slightly off-balance lab result.
It can wipe out whatever beneficial lactobacilli are left.
Exactly, creating a much worse problem. So an asymptomatic patient doesn't automatically get a BV swab. STI screening, however, operates under completely different rules.
Yes, the guidelines recommend routine annual net screening for chlamydia and gonorrhea for sexually active women under 25, or those with elevated risk factors like a new partner or multiple partners.
So a younger patient seeking intimate aesthetic support might receive a routine STI swab even if she feels perfectly fine.
While a postmenopausal patient in a long-term monogamous relationship likely will not unless she presents with specific symptoms.
Exactly. And this highlights why step one in any polynucleotide treatment protocol is the pre-assessment consultation. Before any injections are discussed, the clinician must take a careful, detailed history.
They need to know about menses, sexual history, and really crucial hygiene practices, like douching, for instance, that physically washes away the protective lactic acid and beneficial bacteria, massively increasing the risk of hidden infections.
The clinician is actively balancing global infectious disease guidelines with the patient's personal biological history. They're deciding if the specific profile warrants a quick pH check, a full molecular NAT panel, or just immediate clearance for the procedure.
They act as a clinical gatekeeper.
They really do. And if an infection is found, the protocol dictates an immediate halt. You treat the fungal or bacterial invader, wait for the mucosal ecosystem to completely reset, and only then return to the regenerative plan.
So what does this all mean for you, the listener? Well, we've covered some incredible ground today. We started with the promise of polynucleotides, highly purified technology, using DNA chains from salmon trout to signal native human fibroblasts to rehydrate and rebuild thinning, painful tissue.
And we explored the vital roadblock of active infections, how clinicians use everything from humble pH paper and clue cells to advanced thermal cycling and genetic probes to map that microscopic environment.
The ultimate takeaway is really one of clinical integrity. If you ever consider advanced intimate aesthetics or regenerative therapies, understanding these strict medical protocols is incredibly empowering.
It is. A responsible clinician will actively delay a lucrative, expensive injection to ensure your baseline cellular health is totally secure. It demonstrates that the care provided is rooted in profound clinical safety, not just cosmetic guesswork.
Because you cannot force tissue to regenerate if it is simultaneously fighting a war against an invading pathogen. The biological foundation absolutely must be stable.
Exactly.
But to end today, there is a final, highly provocative thought to mull over, building on the biology we just discussed. The clinical sources note that once these polynucleotide gels are injected, they don't just stay in the tissue forever.
No, they don't.
They are gradually broken down and metabolized by your body's native tissue enzymes, specifically enzymes called deoxyribonucleases or DNases.
It's a natural biodegradation process.
Ah,
These native enzymes slowly clip the DNA chains apart, recycling the material over time as the tissue heals.
But we also know that an active bacterial infection drastically alters the local vaginal microbiome, completely upending the local enzyme environment. And some pathological bacteria produce massive amounts of their own destructive enzymes to break down human tissue.
Which raises an incredible biochemical question.
Exactly. If a clinician skipped the screening step and just injected these expensive polynucleotides into a patient with a hidden, raging BV infection,
wow.
could that altered, highly hostile, enzyme-rich environment not only cause a painful inflammatory flare-up, but actually chemically eat and destroy the injected DNA chains before they even have a single chance to reach a fibroblast?
It is a fascinating collision of regenerative medicine and infectious disease. The bacteria could literally digest the cure before it even works.
A microscopic battle of the enzymes. It is the perfect reason to never skip the swab, and absolute proof that the environment dictates the outcome. Keep asking questions, keep looking deeper, and we'll see you on the next deep dive.